Welcome to Mayo Clinic's ECG segment, Making Waves, continuing medical education podcast. Join us for a lively discussion on the latest and greatest in the field of electrocardiography. We'll discuss some of the exciting and innovative work happening at Mayo Clinic and beyond with the most brilliant minds in the space and provide valuable insights that can be directly applied to your practice. Welcome to Mayo Clinic's ECG segment, Making Waves. In this episode, we dive into the latest updates in the atrial fibrillation management guidelines. These changes have reflected a growing body of evidence supporting early rhythm control strategies, more aggressive use of catheter ablation, and refined recommendations for patients with heart failure and atrial fibrillation. Joining us are two cardiac electrophysiologists that we know very well here at Mayo Clinic, Dr. Christopher DeSimone and Dr. Abhishek Deshmukh. Dr. DeSimone is an associate professor of medicine and cardiac electrophysiologist in the Division of Heart Rhythm Services at Mayo Clinic. He specializes in complex ablation procedures and directs heart rhythm services research here. He has over 400 peer-reviewed publications, holds more than 50 patent applications, and lectures nationally and internationally on innovations in electrophysiology. He also serves as the Director of Marketing for the Mayo Clinic Cardiovascular Enterprise. And joining us as well is Dr. Abhishek Deshmukh. He's also an associate professor of medicine and cardiac electrophysiologist here at Mayo Clinic in Rochester. He specializes also in catheter ablation, a lot of device management in infiltrative cardiomyopathies, as well as in a complex field of adult congenital heart disease. With over 400 PubMed index manuscripts, everyone knows him. Dr. Deshmukh leads research in arrhythmia epidemiology and AI-driven ECG analytics. And he's also the co-director of the Electrophysiology Fellowship Program here and directs the Heart Rhythm Physiological Monitoring Laboratory. Dr. DeSimone and Dr. Deshmukh, thank you so much for joining us today.
Thank you so much. Happy to be here.
Great.
So we got a lot of new updates or exciting updates in the atrial fibrillation guidelines, and maybe we'll start with Dr. Deshmukh. A lot of buzz around these guidelines, and when it comes to new recommendations with catheter ablation and the early management of these patients, how are you seeing, and what's your initial take on the guidelines?
No, thanks, Anthony. No, these guidelines are very well thought through, and a fantastic document for learners in cardiology who are getting into the field of cardiology and learning about atrial fibrillation, because you'll get a historical perspective of what happened and how these evidence came into play. And even for contemporary clinicians who are seeing a lot of patients in AFib, I think it's a fantastic document to go over it. Now, some of the key takeaways from here is now, initially when through medical school and everywhere else, we were taught that AFib is like paroxysmal, persistent, and basically defined by the duration of AFib what people have. But what the guideline has really transitioned to now is that the message is that once you have AFib, you will always have AFib, and it's like a continual disease. And then the arrhythmia progression is divided into, looking at patients who are at risk for AFib, or patients who don't have AFib yet, but they are in the pre-AFib stage. So some evidence of structural or electrical remodeling in the heart, which may predispose them to get AFib. And then finally, once the patient has AFib, then it is duration dependent, whether it is paroxysmal, persistent, long-standing persistent, and then whether they undergo good or successful AF ablation by Dr. DeSimone. And then finally, permanent atrial fibrillation, where you kind of have given up hopes of maintaining normal rhythm. So they have really transitioned it nicely to more clinical utility of AFib from at risk and the management strategy standpoint. One of the other key takeaways, and at least as an invasive electrophysiologist, I'm always trying to see, who will be the best patients to offer an AF ablation, and which are the patients which are going to do better from AF ablation. And clearly there is a lot of emphasis, including class 1A indication, that patients who have symptomatic paroxysmal atrial fibrillation and the aim is to undergo rhythm control, then we should try to ablate them as early as possible. And it was given a class 1A indication. Similarly, patients who have never been tried on antiarrhythmics, that got a class 2A indication, again showing the benefit of AF ablation in patients to have better outcome from the ablation procedure. And mind well, there is also a good section on recurrence of atrial fibrillation after an ablation. That is also key because, if any electrophysiologist tells you that, they have never had a recurrence from AFib, either they are completely lying or they have something secret that they don't want to share it with the rest of the world. But recurrence of AFib is a reality, and it also kind of highlights the approach how to manage that recurrence and some of the downstream effects of ablation. So really, we should congratulate the authors and the leadership group who put together this fantastic document.
Yeah. And Chris, do you have anything, you want to add to that before we kind of look at the heart failure side of things?
Definitely. So definitely underscore what Dr. Deshmukh said. They really did a yeoman's job on this, building on what's been out there, and then really bringing AFib to the forefront and front and center again, right? And it says something when you have all three of the major societies endorsing, United States, Europe, all these areas endorsing a new set of guidelines. So I think this has just been documents in the waiting. And it probably couldn't come out at a better time with the change of an implementation of pulse field ablation now to the catheter set. I would say, along with Dr. Deshmukh's points, one of the major highlights is earlier is better. And not only is earlier better, we're looking at atrial fibrillation as a continual disease, or if you will, even a continual syndrome. So really what we're doing is to improve patients' symptoms, reduce their recurrence, and reduce the progression to persistent AFib. Even when we have these patients that are classified paroxysmal or we think are paroxysmal, there's a long interplay in between persistent all the way back to really, truly paroxysmal atrial fibrillation. And that's where it's difficult to try to put these patients into these certain bins. So that's where the early part of these documents really speaks to us and hopefully speaks to the primary care and internal medicine field, because most of the time, or at least the last few years, based on data in the past about no mortality benefit rate versus rhythm control, a lot of patients have been on metoprolol or diltiazem and rate controlling agents, and they've just been sitting in atrial fibrillation persistently for a long time. So I think this document comes at a pristine time so that we can intervene on these patients earlier. And again, we don't have cures. We will have recurrence with atrial fibrillation, but we have better treatments the earlier and the more paroxysmal we identify these patients at.
And so the two clear things are, even going back to the animal models when they studied AFib begets AFib, that's clear and kind of continued here. And early is important. Now, Dr. DeSimone, when you think of the focus of AFib, we see it with a lot of our heart failure patients. What are your thoughts on the guidelines and how they've shifted to managing AFib in those with reduced systolic function?
Definitely. Great one. And it really comes out in the documents and the guidelines very well. So it's really trying to establish this correlation or this connection between the atrial fibrillation as either being a byproduct of the heart failure or as being the originator. The AFib's the culprit of heart failure and decompensation. So if you initiate that, think about that. We have very, very few medicines or technologies or diets or anything you could think of that will reverse and or cure heart failure. This is one of the only things we have to do that. And if you could solve the atrial fibrillation riddle and maintain sinus rhythm in these patients, they have significant benefits on multiple subcategories of evaluation. So I think the important things that the document highlight is that you need to establish, if you have a rhythm controlling approach, if you establish sinus rhythm, can you recover the ventricle? Can you recover the ejection fraction? And even can you improve structural heart disease like mitral valve regurgitation or tricuspid regurgitation? I think in some patients, I probably even have lean to most patients, if we do have that correlation to where patient was previously fine, healthy, normal echocardiogram, no cardiac disease, and all of a sudden presents in heart failure, and they're in atrial fibrillation as well, very aggressively, we should try to keep these patients in sinus rhythm. And I tell my patients we should take a diagnostic and a therapeutic approach to solving this AFib heart failure conundrum. That is, if we put you on a drug or if we do an ablation, if we keep you in sinus rhythm and your heart goes back to normal structurally and functionally, then we should take every efforts, ablation, drugs, sometimes a combination thereof, to try to improve your outcomes across all measures.
Yeah, and it's the AFib heart failure, which comes first, and it's almost the cycle of both, going to each other. Dr. Deshmukh, any thoughts on, these heart failure patients?
No, I think Chris really nicely outlined, but one thing we need to understand that although the guidelines support AFib and heart failure, that is AFib with heart failure with reduced ejection fraction. So that would be, patients with likely tachycardia mediated cardiomyopathy. They are going fast, and then when you get them back into normal rhythm, their EF gets better. That's an important subgroup of patients because a lot of patients present that way. What the guidelines don't emphatically say, but there's enough signal now with, maybe also some of the work what we have done here, that AF ablation also works in patients with AFib with preserved ejection fraction. So even if the EF is normal, if they have heart failure symptoms, certainly ablation may not fix the heart failure in that patient because the EF is normal. But again, they will symptomatically do much better if they get an ablation for AFib. So really good, a lot of good tips on how to manage AFib and heart failure together. And lastly, it also highlights that, sometimes ablation is not always the answer to treat atrial fibrillation. So, it also emphasizes the node of pacing and AV node ablation, like conduction system pacing or CRT pacing in the right situation to see whether that can also improve outcomes in patients who are refractory to other interventions to control their AFib.
That's definitely correct. And you see that timing, we've talked about it being a critical factor here in the management, and early has been a recurrent theme that I've heard from both of you. When we think about the patient selection, which seems to be important, whether we're putting a device in this shared decision-making process, which Dr. Deshmukh just mentioned, maybe you could walk us through, a patient that comes to you in this, and whether you're trying to decide antiarrhythmic drugs versus ablation, and what is the right option or things that are cluing you in.
Yeah, no, everybody's approach is going to be different here, but as electrophysiologists, we are also trying to identify the right patient whom we can offer ablation for success for the patient. But more importantly, we should not forget that at heart we are all internists and general cardiologists first, and then became EPs. And with that a background, there is enough evidence now that really aggressive risk factor modification will play a cornerstone in reducing AFib recurrence even after an ablation. And now what the guidelines have nicely done, it has given you clear targets of what is weight loss, so more than 10% of body weight, how much to exercise, alcohol abstinence, those things play an important role in reducing the AFib burden. Now, the guidelines, just as a breaking news for all the coffee lovers, guidelines don't say that you have to stop drinking coffee unless coffee specifically is a trigger. So at least for our patients, we should not have them stop drinking coffee in case, unless it is a clear trigger for AFib. Now, what the guideline also has carried on really nicely over the years, that there has always been a debate about rate control versus rhythm control. And the guidelines in one of their tables have clearly suggested how to approach rate control and rhythm control, and which patients would be a good candidate for rate control versus rhythm control, so that they keep it in two separate buckets. And then there is that equivocal patient, who may benefit from either ways. And they also support a trial of cardioversion in that group of patients to really see whether we can actually make that patient feel better in sinus rhythm after a cardioversion. So the guidelines have outlined that patients who have had more recent onset of AFib, rates difficult to control, more symptomatic, more LV dysfunction, or more AV valvular regurgitation, those are the patients who may benefit more from rhythm control compared to patients whose rates are easier to control, patients who are older, not many symptoms. Those are the patients who can go for rate control. So at least in clinic, when I see the patient, I emphasize on risk factor modification. And if they have been in AFib for a considerable period of time, I at least offer one or two trials of amiodarone with cardioversion to try to see if we can bring them back into normal rhythm, to really make them feel how they could feel in AFib and versus normal rhythm. If they don't feel any difference, then we can go for rate control. But if they actually say, well, my fatigue has gotten better, and a lot of times the AFib just creeps onto somebody. So when they get off AFib and they are back in sinus rhythm, they may feel their exercise capacity is better, their fatigue is better. So I go by all the clinical clues and physical exam clues what I can get when I'm evaluating a patient.
And Dr. DeSimone, any, final thoughts on that?
I do. So just a few things to add, and it's kind of latched on to what Abhishek's already alluded to. When we offer these patients these options, I would say it's fair for all of us, all of my colleagues, when we bring these up to patients, it's always going to be risk factor modification. So it's going to be ablation plus risk factor modification. It's going to be rate control plus risk factor modification. It's going to be pacemaker and AV node ablation plus risk factor modification. I think that just comes inherent. It's not like, well, I don't want to give up drinking, so I'm going to do the ablation. Or I want to come off anticoagulation, so I'm going to do the ablation. That's never the right answer. We're always trying to risk modify. And that gives the patients invite and a get to what are they going to get out of this if they quit smoking, if they quit alcohol or reduce alcohol use. It's something that they get out of it. And that brings me to my second point here. You know, when we're talking about this binomial or other little silos we put patients in to say, look, this is a persistent, this is a paroxysmal, this is a patient that might like ablation, this a patient would be great for ablation. I really, I know Dr. Deshmukh as well, really put it out to the patients in a non-judgmental way. I want to do what they're most comfortable with. If it's starting with ablation, I'm happy to offer that. If it's starting with a drug, seeing how well they do, how they feel. Some patients hate how the drugs make them feel or don't want to be on any drugs and they want to do ablation. I think that's fine. Some patients don't want to go through a surgical procedure, even though we're doing it percutaneously. And I think that's fine. I think you got to let the patients make their own decision. You give them an unbalanced option and the best evidence you have, and you give them nothing to sort of sway them in which way you would lead until they ask you for that information. So then the patient's really telling you, here's the treatment I want for this atrial fibrillation, because it's really going to be lifestyle modifications and everything we mentioned to you. All of this is for symptoms. It's what they're willing to give up versus what they're willing to get feeling better. And what risk are they going to take to get what benefit? So I really think the patient's the overwhelming driver here, and that's what the guidelines kind of push you towards. Where we stand on the electrophysiology side as proceduralists is to say, here's my thoughts and here's my perception of the situation after you've told me your wants and wishes. And that's what we bring of artistry to electrophysiology. It's not a cookbook. Okay, this person is X number of years and has this number of comorbidities, they would do better with meds. This patient's extremely healthy, they're young, they do better with ablation. You really got to carve out with the patient, are they the right person to benefit? Do you think that one procedure that you're going to do is going to lead them to another procedure down the road with recurrence? And or do they need to be on an antiarrhythmic drug given the aggressiveness of their AFib when you're starting? All of those things come into play in our minds. And that's what we could offer the patients when they ask us for our feedback or input in this situation. If you get all of those right, then it becomes a really good tool and it's sort of a therapeutic and medicine modality because you're letting the patients choose, you're letting them engage in their care, and then you're really helping them out by applying the art form to medicine, which we all love to do and all we all want to do and should do for our patients.
That's great. Thank you both, for joining us. I mean, it's really clear that the atrial fibrillation is with us, and then when we bring our patients with us, it's not for any short term; it's a long-term journey. It's a long-term journey of trying to figure out what's best with them. And as they both mentioned today, it's going to look different for everyone. And sometimes, atrial fibrillation is not symptomatic, as Dr. Deshmukh mentioned, but sometimes it might be the thing that provides a lot of quality of life improvement. The guidelines are clear that, atrial fibrillation will progress, and we have to do a good job of monitoring, and maybe early intervention makes sense for some patients. Dr. DeSimone and Dr. Deshmukh, thank you so much for sharing your time and your perspectives. I wonder if, Dr. Deshmukh, maybe one final word. Do you have anything to say here before we end?
Yeah, just wanted to sum up everything very nicely done, Anthony. But everybody's AFib is different, but the treatment for everybody's AFib still remains the same. Rate control, rhythm control, anticoagulation, and ablation. So at this point, we don't have a personalized approach like which patient is going to do better with which therapy. But we are kind of throwing the kitchen sink. But now throwing the kitchen sink, we know, what all we should throw in that kitchen sink and what we should not throw in the kitchen sink, depending on the patient population we are dealing with. So thank you again for inviting us.
No, thank you. I think that's a really important point is the guidelines kind of giving us that kitchen sink of what we should use and can use, but, making that art of medicine really different for each patient. Again, thank you, Dr. DeSimone, Dr. Deshmukh, for joining today. We hope to have you back and really appreciate your time.
Love to be back. Thank you so much for doing this.
Thank you for joining us today. We invite you to share your thoughts and suggestions about the podcast at cveducation.mayo.edu. Be sure to subscribe to a Mayo Clinic Cardiovascular CME podcast on your favorite platform, and tune in every other week to explore today's most pressing electrocardiography topics with your colleagues at Mayo Clinic.
This has been a Mayo Clinic podcast.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.